See how it pops in? You notice that? Okay, very good. Great. A very important clue that we're luminal, as you can see, is the bleed back from the quick cross. So we know that we're luminal, and you see this flow. And this is a good sign that you're luminal rather than subintimal. So what we have compared to our original picture is we have now our 6 French bright tip catheter into the right common femoral artery, extending into the distal portion of the right external iliac. We have now exchanged our wire to a 035 wire, and we have on the left common iliac our Lima catheter, which we're using in injections. Our next step is to take our Lima catheter, exchange this for a 035 wire, and we're going to take a bright tip 6 French sheath selectively into the right common iliac. And I'd like to magnify this so you can see that the advantage of this bright tip is that you know exactly where your catheter tip is. Now I'm positioning it just above the ostial of the left common iliac for our injection purposes. Typically, like to check the ACT every 20 minutes. Our range of ACT should be between 225 and 250. I'm going to take a picture with both sides so we can identify how long the stent that we need. So we have a dual injection now. We have access with 6 French on the right and left common femoral, and I have a syringe, 20 cc syringe, so we will do simultaneous injections as we use this as our measurements for our placement of our stent. And it's quite obvious now, we do have the chronic total occlusion, and so we have our access 6 French on the right and in the left. We have our opaque markers positioning us. We know that there's a moderate to severe lesion inside the left common iliac, and so we're going to begin by pre-dilating the chronic total occlusion. So our choice is that I typically like to undersize it by 2 millimeters. I think this is maybe a 7 or 8 millimeter vessel. I'm going to use just a 5 millimeter balloon for pre-dilatation of the chronic total occlusion, and then from there I'll expand it appropriately after we take some pictures post-dilatation. And so we're advancing a 50120 balloon through the chronic total occlusion over the 035 wire. I'm able to do this because I chose a thicker wire for more support, and I can feel at the bifurcation that it pops through the lumen. This is a balloon. As we're expanding, we go just barely below nominal, just enough expansion so we can get some luminal gain for an injection where we can measure the true luminal size. I typically like the inflations prolonged, especially when we have a vessel that's chronic total occlusion. There's a lot of calcium in the vessel. The matrix is very tight, and when you undergo a prolonged inflation, you allow for the matrix to break, especially when the calciums act almost like a napkin ring around the vessel. And so prolonged inflation helps get better angiographic results, but in particular, any chronic total occlusion, you help tack up the vessel, and you get much better luminal gain. So typically about 4 to 5 minutes for chronic total occlusion. Okay, so what we're going to do right now is simultaneous kissing, and we're going up simultaneously as we visualize the vessel to make sure there's no pinching off. Okay, let's take out this balloon once it's deflated. It's very important, when in doubt, take different pictures at different angulations, and so that the precision is very important, especially when it comes to the common iliac. And so we did a simultaneous injection from both sheaths, and you can see that there's still a residual, as we anticipated, in the left common iliac. We have a luminal gain in our chronic total occlusion, and we also see that there is a residual lesion at the previous chronic total occlusion at the left common iliac. We also see that there is nice lumen that's patent after opening the chronic total occlusion, and we see some residual, perhaps a little bit of thrombus in the distal external iliac. Restructuring of the carina, and so we're going to freeze this, and we're going to place our stent. So we're placing one stent at a time, starting with our shorter stent. And so we're placing now our long stent in the chronic total occlusion. You have wire? At this point, we place the stents exactly adjacent to each other, and I'm going to unsheath the left common iliac. The stent, just by pulling my sheath back, which allows me better measurements. Okay? And so that's 28 millimeters. We're at 28 millimeters. We're talking apples to apples, so you're on this side. Prepare for simultaneous kissing stents. And now, simultaneously deploy both stents, and we're going to do it slowly since it might slip. Okay, go to 4.
4.
Okay, then go to 6, Ahmed.
6.
After deploying the simultaneous kissing stent, we do mega negative, deflate the balloons completely so there's no air inside the wings of the balloon, and then we advance the balloon and we try to flare it distally in the distal part of the stent. This helps to assure good apposition. When deflating the balloon, we bring it down slowly, and we do it at 2 atmosphere intervals. If one balloon is deflated faster than the other balloon, there's a good chance that you can compromise the stent. So the monitor on the right shows our original image, which has a chronic total occlusion of the right common iliac extending to the right common internal and external iliac with reconstitution in the common femoral. There's a focal lesion at the left common iliac lesion. And so now we're going to take our post-angiographic pictures. So we're seeing a formal injection, and you can see we have good TIMI3 flow, good apposition of the stents. The reconstructed carina appears not to have any obstruction, and we have very good luminal flow. It's TIMI3 flow bilaterally, and if you compare it to the screen on the right, that was the lesions before, and you can pan from left to right to see the before and after shots. We have revascularization, post-revascularization with 2 kissing stents in the bi-iliac aortic area, and we have an extended self-expanding stent in the right external iliac. As you can see, we have a TIMI3 flow, very good apposition, and we now, if we connect our pressure to the right common femoral, which had a 0 pressure because of the chronic total occlusion, I'm going to direct you to the monitor where you can see now that prior to the procedure, through the chronic total occlusion, there was an extreme gradient with no pressure flow. It was flatlined. And now the pressure flow shows the systolic and diastolic pressures that's equal both on the right and left common femoral with good flow, and showing that the pressure gradient has dissipated. In conclusion of the procedure, it was done through a 6 French sheath, which is about half the size of a dime. This concludes our case of a complex iliac total occlusion. I am Dr. Elder. Thank you for watching.